Okay. So the first thing I want to just communicate with you today is that my role as a pelvic health physio isn't just to provide supervised pelvic floor muscle training. So just to blow your mind there, it's not just pelvic floor muscle training, but, and indeed a pelvic health physio should be providing evidence-based management interventions, bladder training, lifestyle advice, as well as the coaching and the motivation. So of course, I want you to know that that's what we're doing in clinic, but I want to start with the obvious, that pelvic floor muscle training has been demonstrated to be a really efficacious treatment when it comes to managing and even curing stress urinary incontinence and mixed urinary incontinence. We've got level 1 grade A evidence in the form of NICE guidelines here in the UK, ICI recommendations, systematic reviews that suggest that pelvic floor muscle training should be offered as kind of first line treatment. So I want to start with the basics there. And this study, in particular, a study that was undertaken by my colleague Chantal Dumoulin in 2014, kind of has demonstrated this really. So it's just one small study I want to kind of tell you about really. And in it, they included 18 trials with over 1,000 women who'd been diagnosed with stress incontinence, stress urinary incontinence, mixed urinary incontinence, and urge urinary incontinence. And they compared the effects of pelvic floor muscle training with no treatment, placebo and sham, and demonstrated that in the pelvic floor muscle training arm, there is up to a 56% cure rate, improved quality of life, and fewer episodes of urinary incontinence. And what we noticed that the effect size was actually larger in the patients who, where their pelvic floor muscle training was supervised, and in patients with purely stress incontinence. So these are really positive results, and they're positive results in the physio world, where we struggle at times to demonstrate our worth with these sort of behavioural interventions. We know that this works. So that's where I want to start. And as a result, I would really encourage you to ask these questions of yourself. Do you know how to encourage a patient to train their pelvic floor in clinic? Could you help a patient to do that? Could you advise them on the instructions that they should be given? And have you, I guess, developed good links with your MDT members who might be able to facilitate that process? And I would just really encourage you to be doing that as you leave here this weekend. So when it comes to a write-up, I'm not going to repeat Marcus, because obviously we've spent some time talking about what we do from an assessment and a diagnostic perspective, but I just wanted to reassure you that in the physio clinic we would be basing our write-ups on ICI recommendations, as well as the local and national standards that are expected of us. And the consenting patient will then undergo a physical exam off their pelvic floor. And before we kind of go into that, I just want to see if we can remind ourselves of some of the theoretical rationale as to why pelvic floor muscle training might be helpful. So essentially the aim is that we're trying to build up the structural support within the pelvis to increase the levator plate to a permanently higher position within the pelvis, and really optimizing that hypertrophy of the levator ani musculature will stabilize the bladder neck, or it can stabilize the bladder neck, and prevent, and the urethrovesicular structures, and prevents kind of that downward descent during increases in intra-abdominal pressure. So really the idea is that we're building up that stiffness, but there's a few other factors that I want to get you just to consider as you're looking at a pelvic floor muscle contraction. Yes, we need that optimal tone, that optimal resting tone of puborectalis, like Maddie was saying right at the start, but also we want to be able to demonstrate in clinic that there is good muscle contractility followed by an ability for that muscle to relax again. You know, it's a coordinated contraction. That's what we're looking for in our assessment. Good tone, ability for the muscle to contract followed by that relaxation. And that's what we're trying to facilitate for our patients who then have to go home and to rehab. Does that make sense? So when it comes to actually facilitating that process, there are a few key factors that I would really encourage you to consider. So the first thing, what is the verbal prompt that you're using with your patients in clinic to elicit a pelvic floor contraction? We have increasing research, more recent research, that demonstrates that a posterior cue is more effective in bringing in the whole levator ani, as it were. So, for example, I would encourage my patients to be tightening their back passage as if they were stopping wind from escaping. That seems to be a more effective verbal prompt than, say, asking someone to squeeze and tighten their pelvic floor as if they were stopping the stream of urine. The second factor I would really encourage you to consider is that pelvic floor contraction correct? What other muscles can you see kicking in? Is there lots of abdominal activity? Are their shoulders rising? Are their eyebrows rising? These are probably indicators that it's not their pelvic floor that is working there. And actually, we've demonstrated that up to a third of women can't accurately recruit their pelvic floor, and up to 25% of women will actually perform a Valsalva when you ask them to tighten their pelvic floor. So, you know, we've got to identify the muscles correctly, and those patients need to know what they're training. Having made sure that we're giving the right prompt in an assessment clinic sort of setting, and having made sure that it's the right muscles kind of kicking in, we then need to observe and palpate both those things happening. So that's what we would do with a consenting patient. The challenge that we have really is that there are multiple different techniques in the literature that are recorded for identifying a pelvic floor muscle contraction, whether that's ultrasound, whether that's a digital assessment, whether that is perinometry. And indeed, there are upward of 25 different digital assessment techniques that are reported in the literature. And really, there's probably not one perfect assessment tool that, perfectly demonstrates compression and elevation of the pelvic floor musculature. Having said that, and actually on top of that, we could question the sensitivity of a digital assessment unless really significant changes of force exist, really. Having said that, some of my physio colleagues who've been really active in producing this quality research that I'm talking about have stated that pelvic floor palpation is a really helpful assessment tool for teaching and understanding and giving feedback to patients about what a pelvic floor contraction should look like, and it's the recommended technique in a clinical sort of situation. And indeed, it is the mainstay of a physiotherapy pelvic floor assessment. I've kind of gone through some of these pieces already about the verbal prompt and is it correct, and looking and then palpating. So I'm just going to skip on here. So when it comes to the digital assessment, I would simply use a single digit or an index finger to move throughout the left and right side of a pelvic diaphragm. And initially, my assessment will just involve feeling for muscle length, end feel, pain, and symmetry. And it can be quite helpful in this setting to consider the pelvic floor or the levator ani musculature as a clock face, working from between 1 and 5 and 7 and 11. I mean, Madhu has already highlighted to you obviously the 3D nature of these structures that we're talking about, but certainly in a clinical setting, I'm less obsessed about specific musculature, whether I'm specifically on puborectalis or whether I'm on ischial or iliococcygeus. and more to begin with, getting an idea of the global sort of muscle presentation. Having palpated, the next step is for me to then grade the muscle score. And in the same way as there are multiple assessment modalities used and noted in literature, and upward of 25 different digital assessment techniques, there are also multiple grading scores that are recorded and utilised. This one here is the modified Oxford grading score, which was first developed by my colleagues Jo Laycock and her team back in the 90s. And this particular assessment tool grades pelvic floor musculature from a 0 through to a 5. Have you guys seen this score before? You would use this regularly. So this is probably the score that's used most frequently in a physiotherapy clinic. 0 depicts no contraction at all. 1 would be a flicker. 2 would be a contraction of the musculature without a lift. 3 out of 5 would depict a lift of the levator ani. 4 against resistance, and 5 would be a full and perfect contraction. Having graded muscle strength, we then want to fill out that picture even further and look at the quality of the contraction. And we would do this by assessing the duration that a patient can hold that muscle contraction for, and the number of repetitions that they could perform before fatiguing. And that in and of itself is a helpful process, because we can use that information to then help guide exercise prescription. So in a clinical setting, we would use this perfect score here. I've included this for you, but this allows us to look at a patient's ability to perform those slower, longer holds, and as well as looking at some faster contractions, so that we can really optimally train a pelvic floor and help to facilitate that pelvic floor muscle training. When it comes to a specific program that patients should be adhering to, there seems to be less of a consensus. And the reason for this is because different pelvic floor muscle studies seem to compare very different training programs and use different outcome measures. So there's not any really robust evidence to say that if you go away and complete 5 slow contractions, 15 quick contractions, followed by 10 slower contractions or submaximal contractions, that's going to be the curative program. In the UK, the NICE guidelines do suggest an 8-second hold repeated 3 times a day for 3 months, but that seemed to be the lowest number of repetitions that would be reported in the literature. And this particular study by Haysmith et al. 2011 compared 1,400 patients who were doing different training programs with different degrees of supervision over different periods of time, and they weren't able really to recommend any specific program, but they did note patients who were supervised did better, and generally more follow-up was more beneficial. Which is why really we're pushing for this supervised pelvic floor muscle training, as it were. When it comes to me providing a program for patients, I think I keep it relatively simple. The first and most important thing is that they understand why they're doing what they're doing, and they understand maybe a little bit about their anatomy and how they work, and the importance of looking after themselves. So I will use models and pictures with them to get them on board to begin with. I will then verbally teach a pelvic floor contraction. And like I've kind of said to you already, focusing on making sure that I can recruit as much of that pelvic floor musculature as possible with the correct cue. I will then go on to supervise that pelvic floor kind of training program alongside assessing them, send the patients away with written information so that they can remember and retain what they're supposed to do, and then of course follow these patients up. And I think that really is an important factor there. One of the biggest predictors of a positive outcome is adherence, and it also happens to be one of our greatest challenges, really. The most significant barriers to adherence have been explored in the literature. This particular study provided or asked patients to fill out a survey where they asked the clinicians and the patients respectively what they felt that the greatest barriers to adherence were. And really interestingly, the clinicians kind of felt that it was just because the patients had forgotten what they were supposed to do and just weren't motivated. Whereas when the patients were asked why they weren't adhering, it seemed to be because they didn't actually understand the positive results that were available to them when they would do the pelvic floor muscle training. And so really the clinical implication there is, what do your patients understand about why they're doing their exercises, and can we explore their beliefs? I appreciate you guys won't have all the time in the world to do this with your patients in clinic, but even just starting to drip to them information about the fact that there are positive results available to them would be an excellent start. And really, I'm out of time today. I just wanted to give you a brief introduction, but these sort of modalities come up in conversation regularly with me. So, I appreciate that one of the biggest reasons, or the most significant reasons, that people will struggle to adhere with pelvic floor muscle training in the long run is because of time, is because it requires maintenance. And as a result, different modalities have been developed to help to facilitate that process. Vaginal cones, biofeedback, e-stim are three of the main types recorded and reported on in the literature. And what I would want you to take home today really is these methods can be helpful. The research says they are no more benefit when either used in isolation or in combination when compared with pelvic floor muscle training. But if a patient is really struggling to identify and know where their pelvic floor actually is, then absolutely e-stim can be helpful in those sort of settings. And the NICE guidelines do recommend them. And indeed, other modalities like biofeedback devices such as the LV device, that's one that's used quite frequently here in the UK, can be helpful to encourage patients with that long-term adherence. And when it comes to kind of persisting, really the hard bit is building the muscle strength. That's the bit that requires 3 to 6 months of supervised training. Once our patients have done that, maintaining that muscle strength is a bit easier, and hopefully that they will have made some lifestyle changes and made positive health decisions which we can help with so that they can keep up that pelvic floor muscle training in the long term. That's me. I'm done for today. Yes, absolutely, yeah.
Can you make a comment on levator revulsion?
Say again?
Can you make a comment on levator revulsion?
Levator revulsion. So this is this is what Maddie was saying earlier on. Everyone's obsessed about whether or not it would give rise to prolapse, vaginal prolapse, and my understanding and the thing that the main factors I've seen from Dietz's work is levator revulsion is not going to be repaired. What we want to try and do is compensate and strengthen the muscles as much as possible to limit any onward kind of issues, as it were. I mean, would you add any more, Madhu, to that?
I mean, the problem is, you can do transcranial ultrasound, you can do MRI scans, then you can pick up these defects. The question is, what it means for the outcome.
Yeah.
Probably we don't know. Whether we stitch the muscle up or whether we do a different type of technique. I think it's difficult to comment on that. But it's another information. Potentially, might be useful if you have more data on it in the future to say maybe if you have a leftover avulsion, you might have rectocele. I don't know. At the moment, it's a bit of a grey area.
In terms of the clinical application, for me, it's helpful to note, and it's certainly helpful to palpate. I would, but the implications are I need to strengthen a pelvic floor. It needs to be a coordinated contraction. Too much contractility, too tight can result in issues. A lack of timing, a lack of coordination also can result in issues, which is why we want to spend a decent amount of time with these patients in clinic, helping them, getting them to understand what they've got to do, and then we have positive results, you know.
And you're doing some work with the with stimulation as well, with Medtronic.
Yeah, absolutely. Yeah. So we've, ultimately this Cochrane review here, when they've examined the larger data and looked at the quality results, the quality research which should guide our decision making, there doesn't seem to be, robust evidence to say that every patient who has pelvic floor weakness should be having e-stim, but it can be a helpful adjunct. And there are certainly there's lots of technology out there, from chairs through to vaginal probes, through to underwear that you can wear that will provide this sort of stimulation. The message I want you to take home.
Stimulating underwear?
Yeah, there's loads of different things. But there are, the message I want is, to begin with, it involves a bit of hard work and a bit of hard graft, and we can help with that, absolutely. Ask.
How do you decide that this patient is cured or he doesn't need to go back to the surgeons, and how do you assess them?
Yeah.
And what do you tell them about carrying on with their training? I mean,
Yeah.
after 3 months, if they stop, will it go back
Yeah.
to what it was?
So I think what Marcus has highlighted to begin with, when we're doing our write-ups, we would be doing these outcome measures, and we would be trying to use validated scores to identify how much of an issue the patient's presentation or symptoms are, and we would revisit that. So if a patient is coming back and they've told me that they've gone from an ICIQ short form where they're 18 out of 21 and really symptomatic, and they've improved, that they've come down to a 5 out of 21, and they feel that they can manage their symptoms and they don't want any further intervention, I'm not going to be sending them back to see you guys. Answer your question?
Yeah.
So
how long do they carry?
Yeah, and then in terms of long term, they need to keep going. Okay, they need to keep up with their pelvic floor muscle training, and what we would typically advise is once a day for the rest of your life would be what I would be saying to my female patients. By the time they've done 6 months of sort of rehab with me, and I've got them maybe doing it 2 or 3 times a day, once a day is generally more manageable and integrated into their day-to-day life. So yeah, that's what I would be encouraging in terms of long-term adherence. Yeah.
How often do you see them? Is there a structured program where
Yeah.
Patients are followed up in your clinic?
Yeah. So I work in a busy NHS clinic where we see upward of 3,000 patients a year between a team of 3 of us. So it's tricky for us to see these patients on a weekly basis. But there are absolutely some clinicians that would be seeing people more regularly, and the research says more follow-up, more supervision gets better results. So I'm not necessarily working in line with what I could be because of the pressures on me. Very practically, if a patient can demonstrate that they can perform a pelvic floor contraction and they're on board with their rehab, I may well send them away for 3 or 4 weeks before getting them back and reassessing. If they have got very little going on, I would be seeing them much more regularly. If they were sort of a 1 out of 5 on that Oxford score, I'd want to make sure if I send them away, they're getting follow-up, keeping them motivated. And if they're improving, I get them back in a month's time. It might well be that I could get them back the following month, and so on and so forth. Does that make sense?
What's your experience with the difficult group of the overactive pelvic floor
Yeah.
patients?
Yeah. So I think it's really important here that I start with, again, what the science and the research says. And we haven't got loads of data out there that suggests normative values, that suggests to us that having an overactive or tight pelvic floor needs to be dealt with. What we have got evidence for is this stuff. Saying that, there is a lot of discussion going on that focuses around this concept of a pelvic floor contraction needs to be coordinated. And if it is overactive and tight, if someone demonstrates, I guess clinically, that they have pain when you palpate their levator ani musculature, if they demonstrate that sometimes it might present like there is no pelvic floor contraction at all, and it is because they are, in a clinical setting being assessed, anxious, they don't know how to relax, or it may well be that they've just compensated because they don't want to be leaking and they don't want to have the symptoms maybe associated with prolapse, and that can lead to problems. So that, again, the take home for me and for you guys would be, can you feel their pelvic floor relaxing? Can you feel it contracting? Can you feel it relaxing again? And there are lots of different concepts that, again, are not really evidence-based at the moment about how you can encourage a pelvic floor to relax, some of which have been very helpful, that include dealing with things like myofascial trigger points, which is a very controversial sort of topic in the pelvic health world. More hands-on techniques to relax a pelvic floor. This is all stuff that hasn't been demonstrated, but it certainly can be helpful to think about it in a clinical setting.